So in keeping with our attempts to go through all different types of healthcare plans and how things work as a unit, our next speaker is Greg Gieseman. Greg is he's the president and CEO of CFHP, which is the Community First Health Plan. It's the one you see on the sides of the buses as you're walking over to the parking lot. And he's going to talk to us about how private health insurance works and how what we can expect of it in the future as well. Mr. Gieseman.
Thank you for the opportunity to spend some time talking with you. If I do appear nervous, that's simply because I try to avoid situations where I'm the lone insurance guy in the room of physicians and attorneys. What I'd like to do is talk to you a little bit about third-party payer insurance. And you'll hear the terms interchangeably used: commercial insurance, retail insurance. And we'll talk about what the difference that makes. I'm going to go over a lot of background and a lot of terms that are kind of at a high level. The intent isn't to bore you or to talk to you about something you already know, but what I want to do is just make sure that we understand the context of the types of things that health plans do and insurers do. Let me see. So what I like to do is kind of go over, just terms so we make sure we're all talking about the same thing. We'll tell you who the big players are in the insurance industry and how many lives they cover. We'll talk about the cost trends and what payers are doing about that. And then we're going to spend some time talking about the Affordable Care Act, which may very well sound like part two of Sarah's conversation, because there are a lot of things that have happened in the marketplace, the market has responded to, they will not be undone. And as a result of that, that changes the relationship that payers have with providers, whether they be physicians or whether they be hospitals. First things is when we talk about third-party health insurance, where the three parties involved are: the first party is the person who technically is liable for paying the bills, or the patient if they're not the same. The reason they may be different in that in some cases the relationship for the person responsible for paying the bills may be the employer, maybe an association, maybe whatever. But it's easiest to think about the first person in this relationship is the patient. Second party in the relationship is you guys, the provider, whether that be a hospital, whether it be a physician. And the third party is the health insurance. That is the company that is responsible for paying the bills according to the terms and conditions of the benefit coverage that the first party has. Now, third-party insurance is different than third-party administrators. You may have heard that term also. A third-party insurance company, as an insurance company, the insurance company is at financial risk for the cost of the healthcare claims. A third-party administrator is an entity with whom someone contracts just to process claims, just to process benefit designs, and they are not responsible for financial risk. In most cases, third-party insurers are also TPAs, and we'll talk about that in a little bit. If we made a list of who are the big players in the third party there, you can go down the list: United Health Group, WellPoint, Humana, Aetna, Cigna, Coventry, and you can see the revenue that they generate. You can see the number of members that they cover. For example, United Health Group, $102 billion in premium it gets each year, and they cover over $75 million. Now, this list also includes private commercial insurance through employers. It also includes Medicare and Medicaid. And you can see the number of employees that they have throughout the country. When we look at this list next year, it will be different because WellPoint has acquired Coventry Healthcare. WellPoint has acquired a Mary Group, number 8 on the list, and Aetna has acquired Coventry, number 6 on the list. As payers look to aggregate covered lives to reduce their administrative cost and also to create presence in areas of the country and states where they currently are no longer practicing. So if we look at those folks and you see all the lives that they cover, how does that translate into actual number of people? And really, third-party insurance,
commercial insurance, retail insurance, is basically two components. One, those that are employer-based, and those that are self-paid. And as Sarah pointed out to us, only 60% of employers provide coverage in 2011, but that's 169 million people, and over 30% of the total nation's healthcare bill. Now, employers can provide coverage in one of two ways. They can do that fully insured, or they can do it self-insured. Fully insured means that the employer contracts with the insurance company, pays them a premium every month, and the insurance company is at financial risk for all the cost of health care. If the cost of health care is greater than the premium that the employer pays, the insurance company loses money. If it's less, the insurance company makes money. What some employers do is they conduct their business on a self-insured basis, which means that they pay claims as they're due, and they are financially responsible for the total cost of care, not the insurance company. So that if claims are less than what they anticipate them to be, the employer recognizes those savings. Generally, employers of about 200 or so employees are more eligible for employer self-insurance. Now, besides the employer-based market, which is 169 million people, there's the individual market where individuals can purchase insurance directly from insurance companies. Generally, that's on a fully insured basis, and there's about 14.5 million people who do that. The individual insurance market is a very difficult market in which to get health insurance, given some of the tools that insurance companies use to not be in this market, quite candidly, given the potential financial risk and adverse selection of patients who elect this type of coverage. As a quick aside, some of the history, and Sarah shared this with you, but since we are in Texas, one of the beginnings of quote-unquote insurance was back in 1929 when Baylor Hospital in Dallas had an issue with school teachers paying their bills. So what they do is they developed a plan where the teachers could prepay for care, and they paid a grand total of 50 cents a month for 21 days of inpatient care. But that only kicked in after the first week of hospitalization. Now, I haven't translated 50 cents per month in 1929 to today's dollars, but it still probably was a pretty good deal. And then within a couple of years, other employers in Dallas joined that, and the lumber and railroad industries have similar plans even earlier than that. So if we have these major employers and they offer these plans, what are the types of plans that they offer, and what are the benefit coverages that folks are eligible for? The first and probably the oldest is the conventional indemnity plan, and probably Dr. Williams and I are the only two who remember that. This is finally the good old days where patients could go anywhere they wanted to. The insurance company just paid a percentage of whatever the physicians billed. As we'll see in a few moments, there isn't a whole lot of activity in this type of plan anymore. And then what insurance companies did is said, well, rather than letting people go anywhere they want, why don't we go out and contract or have a group, a network of physicians and hospitals. Let's negotiate rates with them, and we'll call them a preferred provider organization. And then we'll say to the patient, well, if you go to these folks, you'll get higher coverage than if you go to someplace else. That's the basis of the preferred provider organization. An exclusive provider organization is a subset of the preferred provider organization, which basically says, we have our network of folks. If you go to them, you get a benefit. If you go outside that network, you don't get any benefit. This is typically the type of benefit you see for those organizations that are healthcare providers themselves, where they want to create incentives for their employees to use the services that they provide. Then the next type is the health maintenance organization, which is a system that combines the delivery and the financing of health care. Health maintenance organizations are different than insurance companies. They are regulated differently. They have different financial and operating requirements. The terms of the contracts they have to have with their providers are different, and health maintenance organizations need to provide a defined set of benefits, whereas insurance companies have greater flexibility in providing that level of benefits. In some cases, HMOs will actually share financial risk with providers. And then the next step up in our evolutionary chain is the point of service plan. Typically, health maintenance organizations say that you have to use our provider network, and if you go out of our provider network, there's no benefit. The point of service plan is an attempt to allow and provide for a benefit outside of the network, so that for an HMO, you can then go outside the network and still receive a reduced premium benefit, similar to a PPO plan. And then the most recent plans that are out there in the marketplace are called consumer-driven health plans or high deductible plans with the savings options. And basically what this does is it takes either an HMO plan or a traditional insurance plan, and it says you have a real high deductible. Again, a deductible is that amount you have to pay before any benefits kick in, but there are certain tax advantages by doing that on a pre-tax basis. So the plan combines the tax savings of funding that deductible on a pre-tax basis as well as the advantage of all the other stuff. So if we look at who's in what, and I apologize this slide may not be as clear as we would like, but the brown is the good old-fashioned, good old days, the indemnity carrier. And you guys can pretty much forget about that because it's now down to less than 1% of the marketplace. And you can see that the HMOs, the next bar over, had their heyday, but they're now down to only 16% of the people that have private insurance are in that market. The vast majority still continue to be in PPOs. Some are in the point of service plan, but you see the growing trend on the far right side of the high deductible consumer driven plan. The theory being with the high deductible, the patient would be much more price sensitive in deciding what services they want, and quite candidly, more willing to question and challenge the physician as to whether this service is appropriate. This gives you a sense as to the growth of these types of plans. Sarah talked a little bit about why health insurance is employer-based. And as she started with, employers started to offer that because of the need to recruit and retrain workers. And there have been a lot of studies that said offering health benefits has a positive effect on worker health status and therefore on productivity. There are studies out. So there's a business case from the employer side for doing that. There are also tax benefits to both the employer and the employee to get your health care coverage through your employer. It's not a taxable employer expense. It's not taxable as income to the employee. Obviously, it spreads risk over a group so that one individual, there isn't a wide variation in the cost that each individual would provide. And obviously, you then spread the administrative cost over a larger group. The problem with employer-based health insurance is that not everybody's covered. One is not all employers offer health insurance. And there are other issues associated with it then becomes a key decision factor in whether you want to take employment with a particular employer, particularly if you have a significant health issue. Also, employers do a lot of things in terms of minimum work requirements, eligibility periods before coverage kicks in. So as a result, in 2011, although only 79% of any given worker in an employer was eligible for the coverage that their employer offered, given the waiting periods, hours worked, things like that. And of those who were eligible, the 79% was eligible, only 81% picked the coverage. They couldn't afford the out-of-pocket costs associated with it. They couldn't afford the amount that came out of their paycheck to pay their portion of the premium. So as a result, only 65% of employees who work for an employer who offers health insurance take advantage of that coverage. And when you combine that with the 40% of employers who don't offer it, only 58% of folks who are employed have coverage through their employer, and that's down from 65% in 2000. What this chart will show you is the relative increases of health insurance cost, and we have a couple of graphs here for you. The top one, let's start with this one, and I unfortunately don't have this. If we start with this bar here, this is the increase in the health insurance premium that employers pay. And that's a combination of all the medical claims costs as well as the administrative costs. And you can see that since 1999, that number's gone up 172%. The bar right at top of that, the brown bar, is the amount that the employee pays of that premium. That's increased even greater, 180%. And as a comparison and benchmark, you can see that the workers' earning has gone up 57% and overall inflation at those numbers. So clearly, health insurance costs, and not only on the total premium basis, but also the amount that employees pay, has increased 4.5 times the general rate of inflation. If we put this in dollars, as opposed to percentage, in 2012, the average annual premium for an employer to pay for single coverage is $56.15. For family coverage, that's $15,000, $745. And you can see how that's changed over time. The star next to each of those numbers indicate that that number is statistically significantly different than the previous year. Okay. Now, one of the things that folks like to point to is, well, these health insurance costs have gone crazy over the last 10 years, but it's getting better, because if you look at the first 5 years, 2002 to 2007, the increase is 51%. For the 5 years between 7 and 12, it's been 30%. So the health insurance industry has said, well, hey, things are working. As a member of the health insurance industry, I would suggest that that may not be the case. The decrease in the increase in premium, as I believe, is a function of the environment, of the employment market. It's a function of benefit designs. It's a function of increased copays. So this just tracks the cost of insurance premiums. But as we'll talk about in a few moments, we're covering less and providing less benefits over time. One of the other things people ask me is, of all the dollars that's spent by health insurance companies, who gets it? Where does it go? And this is just the medical component. Again, the medical component is probably 80 to 85% of the total insurance premium. But if you look at this, physicians get about 32% of that. Inpatient facilities get about another 20%. Outpatient facilities get about 24%. And 22% of that goes to drugs. Just to kind of give you a sense as to where all these dollars are going to. And if we break this down even further into reimbursement rates, one of the problems with the commercial, retail, private insurance market is there isn't any national fee schedule to peg ourselves to. You've heard today talks about Medicare fee schedule. There's a Medicaid fee schedule for physicians. There are inpatient rates associated with that. In the commercial world, we don't have any of that stuff. So what we try to do is we tag ourselves to the Medicare fee schedule. As Sarah warned us today, private insurance, we kind of follow along whatever Medicare is doing. But these are the general rates you see across the country. Is primary care physicians generally get somewhere between $115 to $130 of what Medicare gets paid. And again, these are general rates in particular pockets, in particular areas. These will be different. Some may be higher, some may be lower. The big cities are different than the rural areas depending upon the supply of any particular physicians, particularly in the case of the specialists. But again, the specialists get paid multiples of 20 to 60% above Medicare. Okay? So if we look at these costs and we say, well, costs has gone up 172% since 1999, what's driving those costs? And there are a couple of things that drive that cost, both in the short term and as well as the long term. And in the short term, we have some factors that influence the health insurance cost by members shifting in and out of different health plans, because we talked about all those different types of health plans. All of them have a generally different percentage of what the employee pays. So if you go from one plan that covers something at 100% versus another plan that goes to cover something at 80%, you have to take that into account. That's a short-term phenomenon. Obviously, insurer profit levels change depending upon how aggressive stockholders are, also whether or not the employer, the insurance company wants to enter a new market, and the degree of competition among healthcare providers and insurance companies. In areas where there are supplies of hospitals or supplies of physicians, the cost per, the reimbursement to each of those individual providers is less than if you were the sole provider of a particular service in an area. So they're the types of things that impact the short-term cost. What impacts the long-term cost is a little more difficult, and I apologize for how busy this slide is. But the main driver, overwhelming in all the studies that have been looked at, is the cost of technology and the cost of new drugs. Technology and drugs have an interesting phenomenon in that one is they're very expensive, so everybody wants them. They lead to better outcomes and better quality of life, which is a good thing, but they are very expensive and generally cost more than the technology that they replace. And the problem in the healthcare industry and the medical industry is new technology doesn't necessarily replace old technology. So in some instances, providers and physicians go through the same course of treatment, 2 courses of treatment. Also, what happens as new technology is developed in the healthcare industry, not only do you have the people who are currently in line, pent-up demand for that service, taking advantage of the newer technology. You also have folks who would say, well, wait a minute, I wasn't going to do this before, but if it's not as painful, if I have a shorter recovery time, I want that procedure. So you have an increase in utilization at a higher cost, which drives the total cost up. And as new technology is developed and uncovered for a particular course of treatment, it then is used in other opportunities to use that same technology for other conditions is found. So this is really what's been driving the main portion of all these healthcare costs. Obviously, what also has had a significant impact is we're just plain getting older. And as we get older, we cost more to take care of. And also, as an insurance guy, I got to blame somebody else, so I'll blame the drug companies here, in that there's been an increase in marketing of pretty expensive brand name drugs, and that's resulted in an increase of the demand for those expensive drugs. So if that's what's driving the cost of care, what are private insurers doing about it? And private insurers have taken two approaches to this. One was to say, what can we do to reduce the total cost? And then the other approach, since our customer for the most part is the employer, what can we do to minimize the employer's expense? That is, have the employee pay more. But the first major effort was managed care, and specifically HMOs that were introduced in the 1980s. And what this did is it shifted financial risk. Some of us recall that providers went at financial risk to do some things. And what HMOs did is we went out, we beat up on providers for reduced prices and reduced reimbursement, and we said, well, we're going to give you more volume if you give us better rates. And then we said, well, we're going to do a bunch of pretty significant utilization management activities. Before you, as a PCP, before you make a referral to the specialist, you got to call me up and get approval to do that. Before, as a specialist, before you make a referral to another specialist, you got to call and get approval for that. And that had some impact on costs for a period of time. However, employees began to complain to the employers about the reduced access. Again, remember in an HMO environment, there was no out-of-network benefit, so you had to go to the providers in the network. Primary care physicians were set up as the gatekeeper, and they authorized everything. People reacted negatively to that. And also in the mid to late 1990s, unemployment wasn't an issue. Employers felt that they needed to be competitive. So this attempt kind of went by the wayside. And if you recall, we showed you the decrease in folks in HMO plans, generally joining the other plans that offered increased flexibility. The second thing that the insurance company said is, well, okay, well, one way to reduce the cost of health insurance expense is let's just cover less stuff. Let's just make employees pay more. One of the ways of doing that was increasing the employees' out-of-pocket cost. When an employer offers insurance to their employees, there's the premium that the employer pays a part of that, the employee pays a part of it. So we increased the part that the employees paid, but we also increased the deductibles. And you can see that in the last 5 years, there's been a 47% increase in the deductible. Again, the amount that the employee needs to pay before benefits kick in. It does nothing to reduce the total cost of care. It just shifts it from the employer to the employee. And then more and more you see benefit designs that express the benefits as a co-payment or percentage of the amount due, not necessarily a fixed amount. And you can see the chart over time of those employers that offer health care coverage. Because the ultimate cost savings measure for an employer is, well, let's just not offer health insurance in the first place. And you can see that over time, particularly in the last several years, from a peak of 69% of all employers offering coverage, now we're down to 61% of employers offering that coverage. One of the other ways of reducing an employer's healthcare costs is to eliminate retiree benefits. Generally, this is most applicable to larger employers, 200 employees or up. But 10 years ago, 35% of those employers offered coverage to their retirees. Now it's 25%. Employers are just plain eliminating coverage for their retirees. And here's what we talked about in terms of increasing the employee contribution. So not only are we asking the employees to pay more on a per service basis, but to pay more of the premium for the insurance. And you could see that of that $15,000, that family premium cost that I showed you before, The employer actually pays about $10,900 of that. The employee actually pays the remaining $4,100. And you could see how that's trended upward over time. The other thing that employers like to do to make it even more confusing is to say, let's just offer multiple plans, because some cost more than others, and let the employees determine which ones they want to pick. And you can see that for all firms in 2012, over half of them offer more than one plan. So it isn't the benefit design for ABC Electric Company, it's one of the benefit designs for ABC Electric Company. And then employers took a step back and said, well, wait a minute, all these things that we're talking about, really all we're doing is just reducing benefits, or we're shifting expenses from the employer to the employee. We're really not doing anything to reduce the total cost of care in the first place. So what can we do to do that? And the first thing we thought of is we said, well, for those people who engage in lifestyles that encourage high cost, let's give them a bunch of information. So we went through an education phase where if you had diabetes, if you had asthma, we flooded you with information about your disease and how to manage that. And although those programs have been beneficial to employees, there isn't any study that says they've had an impact on the cost of care. What employers also did was then provided more detailed information to their employees about what it actually cost. Because if you think about it as the employee, all you know what my health care cost is how much they take out of my paycheck for the premium, and when I go see Dr. McWilliams, I pay him a $10 office fee, copayment. The other thing that employers looked at is, well, let's do wellness programs. Let's encourage people to go to health clubs. Let's encourage them to learn about nutrition and things like that. And again, there is some anecdotal evidence, both positive and negative, about the impact of wellness programs on total health care costs. But despite that, we still kind of do it. And in 2012, you can see that 94% of the employers offer some sort of wellness program, even though there's no evidence that says that it does or doesn't impact healthcare costs. One of the other things that we've tried to do is have employees, when they join their insurance company, fill out an HRA, a health risk appraisal, that says, tell me about yourself. Do you smoke? Do you exercise? Do you wear your seatbelt when you drive? And you can see about 18% of all employers offer that, just to collect some background information that can be shared with their primary care physician. And then the next thing we looked at is, well, how can we actually then have some impact or influence on the management of care, recognizing that insurance companies don't treat anyone. You guys treat folks. And they fall into two broad categories. One is case management activities, where as an insurer we say, who are the people that are enrolled in our health plans that are most likely to incur high cost? There are people who are high-risk pregnancies, there are people who have kidney failure, there are people who have pretty serious heavy-duty medical conditions. And there is some evidence that shows by managing these costs, interacting with these people, ensuring that they follow their appointments, take their medication, go to the right place at the right time, there is some impact on healthcare costs. The other component that we've looked at is, well, what about folks who have medical conditions, mostly chronic, that are not as significant as those who are eligible for case management? Those who have diabetes, those who have asthma. And to the extent there are programs involved that manage those individuals with regard to not only education, but appointment scheduling, medication regimen, and things like that. There is some conflicting evidence that shows these do or do not impact total cost. They impact quality of the care delivered, they impact patient satisfaction, but there is conflicting evidence that shows their impact on total cost. And part of the problem is a lot of this information is collected in different manners, and it's difficult to prove or quantify something that didn't occur. So then third thing is we look at it, so okay, well, what is it that we can do to help providers become more cost effective? And what is it that health insurers have that enable them to do that? What health insurers have is we have data, information, and we have dollars. So Sarah talked about pay-for-performance program, which said we'll create financial incentives and provide information to providers if they do the things that we think are appropriate. What some insurers have done is taken those case management and disease management individuals who reside in health plans and put them in primary care physician offices, which makes the most sense. We've talked about patient-centered medical homes. We've talked about accountable care organizations and bundled payments. Again, similar to what's happening in Medicare, the theory behind the bundled payments, what's becoming more and more in the private insurance marketplace, is to go to physicians, go to hospitals and say, for this particular surgery or this particular procedure, if it costs if the reimbursement to the hospital is $1,000 and the reimbursement to the physician is $1,200, we really haven't done anything to create an incentive for the hospital and the physicians to work together to reduce that total $1,200 cost. So the theory behind the bundled payment is to go to the hospitals and say, I'll give you $1,100 to provide this service. You figure out how much the hospital gets, and you figure out how much the physician gets. And having been a part of those conversations, they're really kind of interesting in terms of the dynamics that occurs. That's kind of the way that third-party insurers look at cost and things like that. But what I want to talk about is, for a few moments, is the Accountable Care Act and the types of things that are causing these relationships between payers, insurers, and providers to change. As Sarah said there's 50 things that are already implemented. These are the most significant one from a private payer. One is insurers can't cut anybody loose anymore. Got to take care of them regardless of their health status. We can't say, I'm not going to cover you if you have a pre-existing condition, or I can't say, I'm only going to cover you at a lesser benefit value. Children are covered now to age 26 on their parents' program. Insurers used to say that, okay, I'll provide you coverage, but once you hit a maximum amount, either on a per year or lifetime basis, I'm not going to provide any additional coverage. You can't do that anymore. Certain costs, certain preventive services, you can no longer have any cost sharing. These things are some of the tools that insurance companies had to manage risk, to manage costs. And they manage the cost simply by not providing it in the first place. But these are going away. My guess is, regardless of what happens next week, they're here to stay. And then what the Accountable Care, Affordable Care Act does is it creates a higher level of transparency and increased pressure, both on your part as providers, but also on private health insurers. For example, one of them is insurance companies now have to have their rate increases annually reviewed by the state insurance department. Now, the state insurance department doesn't approve it, but if it's greater than 10%, as an insurer, what you need to do is post all over your website and all over your material, kind of like the Scarlet Letter, is the Department of Insurance of Texas has deemed this increase unreasonable. Despite that fact, many insurers still do that on their website. The second thing that's pretty significant is insurers must meet minimum medical loss ratios. Medical loss is that percentage of the premium dollar that is paid to medical care. And for large groups, groups over 100, 85% of the premiums that insurers collect, you got to pay that out in medical expense. For smaller groups, it's 80%. What the law also says is that if you don't hit those benchmarks, you got to give money back. And you can do it one of two things. You can write a check out to folks, or you can use it to reduce premiums in the future. Last year, $1.3 billion was funded back and checks cut back to employees and employers for not meeting this thing. What it also does is create an incentive on the part of the third-party insurers to maximize anything that's called a medical expense. So as an insurer, what we then look at are things like education, case management activities. Can they be classified as medical expense? If I have a case manager sitting in my office, it's an admin expense. If I put him in your practice, it's a medical expense. So we have those types of things happening now within the marketplace. In 2014, there are a couple of things that are going to happen, assuming that Affordable Care Act is continued. The most significant one is guaranteed issue and guaranteed renewability, which again means, as a third-party payer, we got to take all comers and we can't not renew them regardless of their experience. One of the other interesting things that's kind of buried down in the law that causes a lot of actuaries heartburn is the rating reforms, where premiums can only vary by area and they can only vary by 3 to 1 based upon age. Right now, insurers look at anything we can think of to rate. We look at industry, we looked at age, we look at sex, we look at, you know, any types of things that we can rate. In 2014, I can only look at those things. Right now, if you ask me what the price was or the cost was to provide care for an older person versus a younger person, for a male, it cost about 8 times more to cover a 65-year-old male than it does a 25-year-old male. For women, it's about 4.5 to 1. That can only be 3 to 1 in 2014. What it means is the older folks are going to be paying less, and the younger folks are going to be paying more. Which becomes an interesting argument, and you've heard a lot of talk about the individual mandate and requiring everybody to buy insurance. But if I'm a 25-year-old male who thinks I'm indestructible and I'm never going to use health insurance, and I didn't buy it before, now I have to pay 3 times more than it used to be, or depending on my income, I can pay $95 a year. All through the debate, I was never really concerned about the individual mandate because I didn't think anybody was going to pay any attention to it. But as you know, the individual mandate does require folks to, everybody to purchase insurance or pay this nominal penalty. I think what happens over time as insurers and payers, what we've realized is the tools that we had to impact health insurance cost, benefit design, cost sharing, we beat up on everybody for pricing. We've done all the things we could do to not insure folks who may cost a lot of money. Those things are all gone away. Our bag of tricks is becoming somewhat limited. What that forces us then to do is develop better relationships with providers and organized groups of providers. And more of the industries, the focus is on cost growth, and we need to look at new and different ways of payment and delivery of care. And what will happen, as you know, Sarah talked about, is we're going to shift away from this transactional model of payment where the payer pays you every time you see a patient and provide a service, to more global payments, more bundled payments, even sharing of risk. And I believe we'll go back to the future in terms of some of the capitation for more organized system. And you can see the mechanism that we're looking at in this paying for value are, you know, accountable care organizations, medical homes, bundling of payments. The message is clear: more accountability among providers, just as there have been more accountability and transparency among insurers. And I think what happens then as a result of that, as a provider, we need to look at how is it that we have the infrastructure necessary to support these evolving payment methodologies, ranging from electronic health records, secure referral sources from primary care physicians, and things like that. And carefully follow what's happening in Medicare, because the private sector follows and mirrors what Medicaid has to say. Briefly, there was also in 2014 2 health insurance exchanges, in that there will be one for individuals, one for smaller employers. There are 4 benefit designs that need to be offered. This is just an attempt to create like an Expedia marketplace so that folks can go in and compare insurance, compare coverages and compare cost. I zoomed through that. There was a lot of stuff. I'd be happy to entertain any comments or questions that you may have. Yes, sir.
6 months ago, we at Western University, we were insured through human resources. By email, or letter, or something, we had to reply to them with our smoking status.
Right.
And those in my family who were under my insurance plan, and for each person up to 3, if you replied to affirmative, they smoked, your monthly payment went up.
Right.
Is that something, you know, for example, you have diabetes, you can go in and see above 9%. Your hypertension, diet drops above 115. Get a ticket for a police officer for not wearing your seatbelt. Are all those things going to be put into health insurance policy?
Well,
that's the higher risk group.
Right. There's a difference between health insurance and if it's insurance, if your employer had a contract with United, Aetna to provide and go at financial risk, the answer is they can't do it. As a self-insured employer, they can do it. That's one of the advantages for larger employers to go self-insured and run the financial risk, is that you have the flexibility of benefit design and you have the ability to put in these types of programs and carrots and/or sticks to incent what they consider to be good
So
behavior.
they'll still cover the pre-existing condition, they'll just pay a lot more for it. I have one other question. It was about the, if you go back up about 3 slides, we kind of discussed going back to the future on capitation. And, you know, having lived through capitation in the early 90s, when it was very exciting for a physician, especially the ones that were going out in practice to start with, to sign a contract and have somebody give you a whole bunch of money at the beginning of the year and say, you take care of all these people and you get all this money at the beginning of the year, and if you don't use it all, fine, you keep it. If you do use it and you run into cost, then you take care of that, which essentially shifts the insurance burden from the insurance company to the physician. And the physicians are not bound by the rules that insurance companies have that say you have to spend, you have to have a, you know, massive money back here that you use in case of a rainy day. You know, they're working on a 24-hour basis in a lot of services, a lot of situations. So how is it that we could let an insurance company, which is huge and has lots of money behind it, then shift the risk to the physician and not expect that physician to go broke?
Well, there's 2 answers to that. In the good old days, quote unquote, when insurance companies could do that and say, here's your capitation, live and die by it, you were still financially responsible for that. In most states, what insurance companies will say to the insurer is, I don't care who you download risk to, you are still ultimately responsible unless that entity, you, are a licensed or insurance company in the state of Texas. So that's one answer. One is it can't happen. 2 is we know much more than we know now. That providers are a lot more sophisticated. There are easier to understand models about how to predict future claims costs, because the industry is somewhat different in that the expense for medical claims, providers have 60, 90 a year to submit a claim. So as an insurance company, how do you know that? Well, on October 31st, how do I know I got all the claims in for October? Because people have a year to submit them. So you have to make guesstimates on that, and there are better models out that are more precise.
Other questions? It was very enlightening. Thank
I
you very
appreciate your
much.
time. Thank you for the opportunity.